I'm going to move on now to the first panel, which is a topic area which is quite big despite its name as well. So for those people that don't work in this field in particular, I just put down a few little facts just to get you to try and think of some of the issues that might be facing. So at the present time, the estimation is there's about 2.5 billion people on the globe who are overweight. There's about 890 million people on the globe who are obese. So these are truly staggering figures. This is a condition, stroke disease, we can debate that in a minute, which actually drives quite a lot of the non-communicable diseases that the NHS and other health systems are dealing with, from obvious ones that you read in the press, like type 2 diabetes, to an array of cancers as well. So the need to have robust management systems is obvious. And it's not just the medical side. The social side, again, is very stark. Obesity is linked to a number of issues such as sick days, etc., and educational attainment in teenagers as well tends to be lower in children who have a higher BMI. There are challenges. There are challenges for these guys who you're going to meet in a minute. A large proportion of obesity in developed countries is in low economic communities. So again, it puts a major challenge on how you put systems in to support people. And we live in a new age, so the actual GLP-1 receptor antagonists, and the tidal wave of drugs that are going to follow that have changed how we can potentially manage it. What I thought we'd do to start with, because it's always nice to know who you're talking to first to get the actual ideas, your ideas and questions that you might want to ask flowing. We're going to ask the panel to introduce themselves one by one. I'd like them to actually tell you a little bit about themselves in 2 minutes, why they're interested in this particular area, and what excites them about the future. Yeah. So should we start off, Chris? We'll go for this one, we'll go that way. And I'll cut you off if you could.
Yeah, please do. Hi, everyone. My name's Chris. So about 10 years ago, I was working for NHS England, and I was completely blown away that the country did not have a comprehensive strategy to deal with obesity and diabetes. It blew my mind. These are arguably completely preventable diseases, and the human impact of obesity and diabetes can't be overstated. So I quit my day job to do something about it. I started a company called Second Nature with a friend of mine, Mike, and our mission was really simple. We wanted to eradicate obesity and diabetes, and we thought technology could be the answer to that. We ended up building a habit and behavioral change program. It's now been used in the UK by about 300,000 people, which has helped people reverse diabetes and come out of the risk zone for obesity. Our program mainly deals with the psychology of losing weight. So we're not a diet. We help people understand why you may be overeating to begin with. About 2 years ago, obviously GLP-1s, the new wave of GLP-1s hit the scene. I was initially extremely skeptical because a lot of my company's narrative had been drugs aren't the answer, right? We can do this through habit and behavioral change. And then when I saw the data, I had to kind of re-examine my worldview of this. And I realized that GLP-1s, while we as a company dealt with the psychology, GLP-1s dealt with the physiology. And I realized that if you could pair the two, then the outcomes would be even more impressive. So we launched a GLP-1 program. So you get our behavioral change program combined with GLP-1s. We've launched that to consumers. we're going live with the NHS in April with the We Go the Manjaro. Yeah, that's me.
Great. One thing you're excited about the future? Just in a sentence?
That we may see a genuine end to obesity in the next 10 years.
Matthew, do you want to carry on?
Yeah, sure. Hi everyone. Matthew Coghlan, and I always like to get any audience on side to start with, so I'm going to share with you the fact that I am a graduate of Imperial College, first class biochemistry 1989. So before grade inflation. It's
like university challenge
still,
now, isn't it?
still the pinnacle of my career, sort of academically, I always think. And then another connection to local area, I then went on to start at Glaxo Group Research in Greenford in November of 1989. So got good connections to Imperial in this part of London. And I won't bore you with my whole career. I spent many years working at AstraZeneca in Alderley Park up in Cheshire, and then Cambridge as the vanguard of AZ in Cambridge in 2008, where I was tasked with building a biologics portfolio for AstraZeneca cardiometabolic therapy area, and that resulted in a number of molecules moving into development, peptide molecules such as cotadutide and antibodies and so on. And then I had the pleasure of building a cardiometabolic research group for MedImmune stroke AstraZeneca in Cambridge over 4 years between 2013 and 2017, at which point I left for my sabbatical in Copenhagen for about 18 months, working for another company that some of you may know of up there in Northern Europe. And then rather than relocate to Oxford, where I would have probably been working for Bill, we had the option to move to the Midwest and to Lilly headquarters in Indianapolis. And that's been a fantastic experience. So we returned last year after about 5 years living and working in Indy. And as I look at this audience, it reminds me that that was an incredible place to work in terms of the diversity of the workforce, people from everywhere, on the planet. And, and it really emphasized to me the value of teamwork. And, we've heard comments about that this morning from Stephen and the head of chemistry. And I think that's so important in anything really, but especially in scientific endeavor, to have that sort of diaspora and diversity of experiences and expertise. So since I've been at Lilly the last 6 or 7 years, I've had a leadership role in the incretin portfolio. So strategizing about the size and shape of that portfolio, were we going to be competitive moving forward? So that's been a fantastic experience. But at the base of that, I've had a role leading preclinical research into how these molecules and future molecules work. How do they act? Why is the next best thing, believed to be such versus what's gone before? And that continues to inform everything we do in Lilly. It's all based in the science and innovation in terms of the biology, but also innovation in terms of the nature of the product itself. So I think as I look to the future, it's really optimism that this disease, and I think most of us here agree it is a disease state, obesity of itself, as the Lancet Commission also sort of describes in the last week or so when that was published. I think the future for obesity care in terms of novel medicines is optionality, so that patients and prescribers have a far greater range of assets in their armamentarium that they can bring to bear. Mm-hmm. So I think we have reason to be optimistic that those molecules are coming, they're moving forward in and through development.
Tricia.
Okay. Hi, I'm Tricia Tan. I'm one of the consultants working at the Imperial hospitals here, but also a clinician scientist. I have worked for more than 20 years in the field of gut peptides, and I've been very lucky. So I've had the opportunity to work in sort of early physiological studies. So I like to think we're one of the first few people who tested how we combine gut hormones in man, showing proof of concept. But I've also had the opportunity to work with Professor Steve Bloom, where we've designed drugs, treatments, GLP-1 type drugs, combination hormones. So worked very much in early preclinical development, right up to taking some of these drugs to first time in humans here at our clinical research facility just at Hammersmith Hospital down the road. And sort of been part of a spin-out, which has now been taken over. So a broad experience, but more importantly, I also do clinics, see patients. And I think what really excites me is the fact that we actually have things we can offer patients as long as we can access the treatment. Access is a slight problem right now, but you know, the fact that there's the option and actually being able to and actually seeing this actually in use has been really exciting.
Bill.
Hi, I'm Bill Haynes, and I work for Novo Nordisk. I'm a physician scientist by background, trained in medicine, was a professor, worked on leptin biology for any of you who are interested in how body weight is regulated, and about 12 years ago moved to the pharma industry, and like Matthew, worked for AstraZeneca for a time, and the past 6 years we've been with Novo, heading up their research in the UK and at their site in Oxford on the Old Road campus, working very collaboratively with academics both in Oxford but across the world, across the cardiometabolic portfolio. I've been interested in obesity for many, many years, both from a research perspective, but then also established an obesity clinic as a clinician in the Midwest of America, which is in many ways far advanced from the UK in terms of the incidence of obesity as well as some other aspects of culture. And was struck there when I saw people with BMIs of 35, 40, 45, 50 with a long list of problems, many of which were not necessarily the ones you instantly think of, like type 2 diabetes, but included mental health issues, chronic pain, anxiety, sleep apnea, cancers as well, and realized then that we really needed to revolutionize the way we approached obesity. And so when I was approached to go into the pharma industry 12 years ago, I was excited to do so. Many of my colleagues have said, you know, I agree completely with what they see in the future. And to get a bit more granular on that, I think in the next 10 years, hopefully we'll have treatments that move beyond what the revolutions we have now, but to therapies that are more scalable to reach more patients in the world. That requires ability to manufacture, but also to lower the cost, but also therapies that avoid or can meet other unmet needs in patients, whether that be the complications of obesity, could be convenience of therapy, could also be the intersection with lifestyle therapies and doing that better as well, and applying digital tools. So I think we've got a really, in the obesity area, a very bright future in the next 10 years, and we've just seen the tip of the iceberg right now.
Okay, thank you. Again, while you're just thinking through your questions, there are a couple of things we're going to ask the panel about. But perhaps firstly, obesity, the drivers for obesity are very complex. You know, they're a mixture of physiology, genetics, and lifestyle coming together. A lot of people would argue that it's a lifestyle condition. I just wonder if we can have a show of hands at the moment. How many people believe that obesity should be medicalized, that it should be treated by medicines? You're on good ground, aren't you? Wow, a few years ago you wouldn't have got that. But what do you think? I mean, what are the challenges, the current challenges for medical management of a lifelong condition?
Shall I try?
Oh, you can start, Tricia. Go on.
I would say that if you're medicalizing, sometimes we're faced with someone with obesity but no other medical comorbidities. But as the Lancet Commission had alluded to as well, is the fact that that no other associated medical condition can eventually lead to other medical conditions. But by medicalizing it, perhaps it can help us better structure how we want to treat obesity. At the same time, but very important for us to also address some of the points that you said earlier, stigma, mental health, and also behavioral changes. So teaching us how to change things, because I can tell you as a clinician, when we see patients come into clinic with lots of medical conditions, so we list down hypertension, obstructive sleep apnea, fatty liver disease, but we always fail to list down also obesity. So we will start them on, blood pressure treatments, cholesterol drugs, but we don't address the obesity. So I think, where you're medicalizing this, it gives us the opportunity to address what needs to be addressed.
Bill, you want to come in?
Yeah, I came to the field through cardiovascular prevention, so worked in hypertension and lipid clinics, and I remember the history. So, for example, President Roosevelt died of uncontrolled hypertension, and back in that era, people would probably have said, should we medicalize hypertension treatment, or should we just give salt restriction in diet? And I think we're on a journey, and the same thing happened with cholesterol in the original day. Even just 20 years ago, many people would treat high cholesterol with diet, and statins were considered almost sort of experimental. So I think as we progress, if we look back 10 years, we'll be like, why did we ever resist treating obesity with medical therapy as we do with these other conditions that we know cause long-term morbidity and mortality?
Great.
So I think if...
Go on.
Well, if you were to go back to... Obviously, obesity is a multifaceted illness. There are many causes for the obesogenic environment that we now live in. But if you were to really simplify it down, so 1970s America, suddenly high fructose corn syrup started to be included in all the foods, and obesity skyrocketed. It literally happened within 5 years. And so unless you were to believe that there was some moral panic that existed in the American populace in the 1970s, so what, in the 1970s everyone just lost all their willpower? Suddenly there was no one had any willpower and they all developed obesity. Well, of course not. The environment drastically shifted and people stopped having agency over their ability to keep at a healthy weight. And I think that framing is very important. And what you'll find, and I'm sure you see this, Tricia, when people who have been on the medications, they'll say things like, this must be what a thin person feels. Food is no longer controlling me. And again, people suddenly say they almost feel kind of seen and heard by the medications.
But I was going to come back and just ask one other thing, really, is because obviously the treatments at the moment are limited. They have you can only treat for a certain length of time. And that's a bit like treating type 2 diabetes and then pulling out the drugs. So, and we haven't got anything effective at the present time for that strategic gap when those things start. And if you look at most of the actual data, weight swings back up again. So I know, Chris, you're an advocate of lifestyle intervention. You believe that we can get a gap there. What is it that we can do? Should we be pushing for lifelong management, or should we be trying to actually use that time in a way to have lifestyle interventions that do actually change people's behavior?
So there's no current medical reason why people should not be on the medication in perpetuity. And that's what Lilly pushed for the Mounjaro tirzepatide NICE technology assessment. Lilly basically went in and said, no, people should be on it past 2 years. The 2-year thing was just the NHS funding gap. The way that I see it is that, yes, some people may need to be on the medication for the rest of their life. Some people may well get an amazing effect from going on it for 6 months, a year, 2 years, making lifestyle changes and learning to change their habits as they go, and then they can come off it. But I think it's not clear yet that there should be a one-size-fits-all approach.
Anyone else want to comment?
I'd say that there is an effective treatment that we do have. That's bariatric surgery. Yeah, we've got over 50 years of data to show that after surgery you get sustained weight loss. Yes, there's a small list of complications that we do have to sometimes deal with, but it's definitely an effective treatment. And actually, a lot of the early work that we have done at Imperial has been based on the findings from bariatric surgery, using the surgery as a model. So your GLP-1 levels after eating is much higher, as similarly with all the other peptides. So it's definitely a nice model. And patients actually come in with describing changes in behavior after surgery. I no longer crave for, the types of food that I used to crave for, etc. So that is one model. So I would say, yes, if we need to treat with drugs, plus lifestyle changes, we need to think about lifelong approaches, whether it's, starting, stopping, rescue treatments, etc. All those things we've not actually looked into in detail.
Bill, you wanted to come in?
I just wanted to echo this idea about precision medicine of subgroups. We really don't understand in patients with obesity what at start whether how well they'll respond to a drug, how well they'll respond to withdrawing the drug, what their risk factor are for complications of obesity. And so I think if any of you in the room are looking for research projects or areas to focus on, thinking about those kind of questions in patients with obesity is really important and a big gap that we have.
Yeah, but I do struggle with that Lancet commissioning guidance because I after reading it, I wasn't quite sure how that would apply to how I would assess someone whether they should go on the treatment or not. So at present, it's a confusion because, a lot of the other metrics that we would use, waist, hips, ratios, height, etc. All those things do also fall within the BMI. So, yeah, it's tricky. And I think people who should be able to access these treatments, the numbers are huge, right? We just don't have enough drugs or enough resource to treat them all.
Bill, do you want to come in?
Well, I just wanted to emphasize the danger of compounding, and you mentioned it. You remember if you give a poorly manufactured peptide, you can actually induce antibodies, and then you may negate your ability to respond to GLP-1s for the rest of your life, or even get weight gain. So it's a concern not for us commercially, but also just for long-term patient safety. And I think we have to be very careful about where these drugs come from and how they're made.
I just wanted to tell a quick analogy. So we prescribe GLP-1s in both the NHS and the private market. And we had a lady come through last week in the private market, and she revealed that when she, to pay for the medication through Second Nature, she'd remortgaged her house, which is just slightly terrifying. What do I do in that situation? Can't tell the person, that's a crazy decision, don't do that. But I just wanted to articulate how for people that can't access the medication through the NHS, and obviously that person that's remortgaging their house, they're probably not in like the top decile for income, right? They're so desperate that they're taking an absolutely desperate measure to access the medication. It's quite scary. And
I'll just add, I think the NHS and NICE are on a classic penny wise, pound foolish. An investment in treating and preventing obesity will confer long-term benefits over 5-10 years that I don't think they've taken account of. And so I think maybe it's on us in this panel and in this room to try and change those kind of minds.
Okay. So just to pull out this kind of second half of that question that the person asked, where does obesity stop and start? Then the Lancet Commission tried to make that, the report that you've mentioned several times, tried to make that clear. But are we really on a continuum? Where should you start management?
Yeah, I mean, it's like type 2 diabetes though, right? There's type 2 diabetes is a line in the sand for HbA1c. It's the same with obesity. It's a continuous scale, but there has to be some criteria, right? I mean, obviously, a huge amount is down to clinician's discretion.
But I think it's like the statin story. You set. I think what we need is an obesity complications calculator, and then for country by country we set limits. And some countries may be able to afford to treat more, and some less. And whether that's a 5%, 10%, 20% risk of a complication in the next 10 years. that's where I would go. I don't know that we're there yet in terms of designing such a calculator, but I think that maybe that's something that people in this room can figure out.
Thank you. Okay, next one, I think Tony rapidly put up his hand there.
As we're discovering from the horrors going on in the States right now, of how it's political, and it seems to me the barrier we've got with the GLP-1
Tony, is
the problem we've got with the GLP-1 based drugs is political. We've got highly effective drugs which are just not getting to the people they want. It's partly financial, but the struggle seems to be much more political, whether that's obesity stigma, whether that's an assumption that this is free will, etc. How do we tackle that, particularly in the UK? You know, we have no infrastructure. I mean, it's great to hear what Chris is doing, but we haven't got an infrastructure. We are beginning to get the drugs. We just haven't got the infrastructure to prescribe them. How do we persuade those in power that there are, as was mentioned, there are benefits in the long term? We will save money. How do we change this politically? Because that seems to be our barrier.
Would love that answer.
Anyone? Chris, do you want to have a go?
I think that the recent NICE technology appraisal of tirzepatide was probably the best example of that, where I do think they considered the long term. The simple reality is that the medicines budgets don't really exist for the different
But
ICPs.
it's also the wraparound care. We don't have that. The NHS, we need to learn from the failure of Wegovy rollout. We've only actually gotten around sort of 60-something patients on Wegovy at our weight centre, which isn't much, right? And because there's been no investment into how you deliver these drugs. You see, the realization of what is actually required.
So that was all. It was all designed, right? There was basically last year, NHS England designed this thing called the Specialist Weight Management Service that was going to have wraparound care, and we were one of the providers that was going to do that. But then with the change in government, it literally got killed overnight, and now it's like 18 months later, and we're still not really sure if that whole project is ever going to be rolled out, and the Manjaro thing confused it even more.
Yeah.
But yeah.
Bill, do you want to come in?
Well, I also think that maybe we need to think about different models for delivering care. I mean, Chris has one where, because of the scale, this is not like treating people with heart disease or cancer, where you can have a specialist, you have clinics, you have outpatients, you have the whole NHS sort of panoply around that. But are there digital-first approaches, video consultations, applying AI and other approaches to reach many more patients?
That needs investment. So it's no different to investing in the NHS.
So
you see, that's the way.
So in summary, there's two aspects. One is the treatment itself, or the drug itself, and then the second is the wraparound care, both of which are missing.
That's right.
And the big pain point was that NHS England started to suggest that it could be prescribed in primary care. So your GP would prescribe it, and then you speak to a GP and they'd say, "Oh, how in God's name am I going to prescribe this in primary care and do the monitoring of it?" And all the GPs
I think
said
it's
no.
possible. We just need to invest, teach, guide. But you need to have that infrastructure. But I've been going round and round this topic for the last 2 years, and it's frustrating because it's a big problem. It's not a small number of people that are affected, and unless proper investment is put in, even though if they provide us with money for the drugs, we're very lucky. In our weight centre, at least we got money for the drugs. That was great, but we did not have any extra infrastructure to support it. So everyone's fighting for this for their patients. So yes, it would be nice if there's a way to rethink how this is delivered.
Can I add one point to this?
One last one, and then we'll get
Because
to
it feels like we're very pessimistic, but if we look to other countries, in the US, as I recall, something like 3 to 5% of American adults are on GLP-1s now.
Yeah.
So it's not impossible to reach many more people, and I'm sure we're on the right trajectory, but it may take some time.
Yeah, but the question is whether they continue on the drugs, right?
Yeah.
So they get the good effect and then they stop. You see, there's not that long-term planning of how we implement these treatments to patients.
Okay. Okay. The guy with the black jumper on. No, it's you. This is black, isn't it? No, maybe.
Gary.
So thank you so much. I invest in tech startups, and I work with a lot of corporates to actually find next innovations. And to your point, I think a lot of people actually about 60% get off GLP-1 because costs and a lot of issues. Most of my clients, most of the stuff actually that I work with, they focus on whole different things, which is mostly the microbiome, which actually regulates the hormones, which it actually regulates how do you behave, and it's actually long-term benefit by having the right microbiome, not the one that craves sugar and salt. So yeah, it's great to be like Lilly, $1 trillion company. Congratulations. But what is the perspective to actually work on on this microbiome projects that actually have a long-term effect?
Okay, go on.
I should say, and maybe Matthew will echo me, that we're interested in lots of things beyond incretins. We're interested in anything that can improve someone's cardiometabolic status, whether they have obesity, diabetes, heart disease, and we're certainly not just focused on things like GLP-1 or GIP or amylin, but the proof is in the pudding. That is, can we design an intervention on the microbiome or on some other area that we think has a high probability of success of actually achieving significant, say, weight loss in obesity in humans. And I'll say that one of the big barriers that we see in the pharma industry is a reliance on animal models that don't translate to humans. And so we have to be, whenever anything comes across my desk, and maybe Matthew's the same, that's almost the first question we ask is, what is the human evidence for causality? But we are very open to lots of different approaches, not just the incretin hormones.
Anyone else want to pick it up?
Totally agree. From my understanding, it's still the idea of the microbiome is still fairly novel in its effect on obesity, but I think it has the potential to be. It's just a shame that Zoe kind of blew up.
We are trying. My research group, one of the major focuses is trying to actually look at how food relates to the microbiome and how it releases some of these peptides that we've been talking about today.
And the weight loss
is incredibly complicated.
Yeah.
Perhaps we'll come back to this in a different setting towards the end of the meeting, but again, give people opportunity. Yeah, sorry, you were first to it this time.
Excellent. Hi, Chris Ward from Innovate UK. I'm interested, I suppose, to widen the conversation into pathway design, because it's very easy to look at the drugs and, as revolutionary and game-changing as they may be, the pathway is the thing that's going to make them effective, and indeed, I suppose, personalised solutions for individual beneficiaries. This touches upon the scaling challenge that we just talked about, because as I understand it, the drugs have to be used and are only mandated if they have psychological support, diet support, and exercise support. Is that the real scaling challenge? And to your point about digital interventions, can you foresee a solution that actually starts to increase the scalability of this missing piece of the jigsaw, but possibly also in a way that delivers benefit to kind of cohorts of kind of those that need treatment?
Yeah, and I'm going to say something controversial that some of my colleagues may disagree with, is that some of these pathways that have been designed are based on, as you say, support with exercise, support with this, support with that, psychological. But actually the clinical trials that led to the regulatory approval didn't necessarily include all of those things. And some of those clinical trials have shown benefits over 4 years. So I guess one plea is that we don't over-engineer the system that then actually means that we restrict the capacity to treat people. And that's why I was thinking about digital approaches that could reassure us that we're giving the advice to patients, but are not limiting the number of people who can get into the system because they can't get an appointment to a clinic, for example, or to get appropriate follow-up. And I think there are ways in which we do that. Maybe the NHS is not the most agile in delivering that, but perhaps that's something we can work on.
Yeah. Chris,
I mean,
your bread and butter.
That's basically our whole thesis as a business. But it's not clear absolutely that everyone requires wraparound care. And in fact, I think I've mentioned this nice technology appraisal 3 times now, but Lilly pushed quite hard in that TA to say, no, there wasn't that much wraparound care in the trials. It may not be needed for everyone. And that's absolutely true.
I think that's going to probably be the direction of travel for the tirzepatide, and where a lot of the prescriptions probably will come from primary care. But nevertheless, I think in the real world, the response to treatment is slightly different, and we need to be equipped to be able to deal with that. But yeah, it's.
I think if you, Tricia will be able to say this far better than I can, but if you've ever treated a patient who is BMI of 40 with multiple comorbidities, they are extraordinarily complex patients, extraordinarily complex. And I think the idea of maybe just giving them the meds and letting them go on with it is bonkers. I mean, the psychological support alone for something in a tier 3 service is, the stories of people that come through our program, you would not believe the complexity that is going on in people's lives.
And I think an analogy is what happens, or what happens in things like high blood pressure and high cholesterol, where the vast majority of people can be treated in primary care with 1 drug, maybe 2. With obesity treatment, for example, we've got single agents, we've got agents with dual actions, there are now ones with 3. We'll have combination therapies, and that's where we're going to need the specialist care as well as the other aspects of wraparound care. And that's, there's not one size fits all, there's probably a primary care element, and then there's a specialist care element for those complex patients who need more weight loss or more support.
But we're not getting investment into, extra staff resource to treat these patients. That's the problem. And I think, nationally, we need to actually rethink how we do this. Because even when we roll out tirzepatide, it's going to be people with multiple comorbidities. But how about targeting people at an earlier stage? There's a lot in obesity which, I probably can talk for hours on this, that we're not addressing.
I'm going to hold you back.
Yeah, stop me. You can stop me.
It's these guys opportunity.
Yeah.
The chap in the middle, I think, does have a black jumper on this time, unless he's going to tell me it's navy again.
She is black. Hi, thanks. Just on that, Tricia, you touched on preventing maybe obesity, and I was just wondering, how are we going to address the fact that a lot more people are going to end up obese, and how do we target them at a younger stage when currently the focus, especially with the NHS, is to treat rather than prevent?
Yeah, so I think you need investment into sort of, how we do this. It's not all going to be drugs. That's the key thing. We must not forget, because there's, obesity is extremely, extremely complex. So where we are just saying, well, let's just get primary care to do X, Y, and Z, that's not the solution. I think, we need to address everything that comes around this complex problems, but obesity is part of the comorbidity.
So at the moment, really, what we're doing is there's a sink with a plug in that's actually overspilling.
Yeah.
We're mopping up, but we haven't learned how to take the plug out.
No, and we're treating
It's really close to my heart.
Yeah, I agree completely on the prevention side, and I think this is where other solutions, it could be digital lifestyle, but maybe it's also incretin-based therapies for the appropriate people. I do remember one research finding from a number of years ago that the biggest predictor of developing coronary calcification at the age of 30 was adolescent overweight or obesity. Mm-hmm. And I think we're missing a chance to really affect long-term cardiovascular health, but also other aspects of health. We don't actually think about young people with overweight or obesity.
Yeah, and I would say one of the focus in the work that I'm currently doing at Imperial is also looking at sort of maternal health, because targeting the mother before pregnancy. And actually, a lot of the trials have ignored women of reproductive age. They're not recruited to the trials, and how we use that safely, and then how we help them from a fertility perspective. So the whole life cycle we've not addressed. We've addressed a lot of the trials have been people in the 40s and above, and yeah, so there's still lots to do from obesity, but I do think that trying to target earlier is important. Drugs are useful tools, but probably not the full solution. And yeah, so hopefully lots more work, and that we don't stop getting investment into work around that area.
Just to follow up on Tricia's points, I wouldn't say necessarily we're ignoring women of childbearing age, but obviously there's guidance there about trial populations and who to enrol and who not to enrol. But the other thing, industry is running obviously trials in adolescents in particular, and actually some younger age children as well. So those data are being generated.
And it's exciting, but I do think if we can also look at women before they get pregnant, and somehow everyone shies away from that because of the preclinical data of how these drugs may potentially affect the fetus.
The prevention angle is a lot more, even more political perhaps than the actual management. You're talking about putting in systems that are able to nudge people towards healthier lifestyles, whether that's food or exercise, building spaces. I don't know, Chris, whether you believe that there are long-term solutions to changing the food behaviour of the population.
There's a great app for it. It's called Second Nature.
You're going to leave it there.
But yeah, I mean, to answer your question.
But as a scientist, I want to make another plea, which is that we apply the same scientific rigor to what we do in prevention as we've done for treatment. Randomized, blinded, adequate power to actually show these work. Otherwise, we end up with solutions that are pushed on people and actually increase people's inconvenience or costs to society.
Yes.
Yeah.
I just had one. Sorry.
You've got to wait for a microphone. I know you're desperate, but you've got to wait for a microphone. Then I'll come to you, okay? Go.
Thank you. I'm Ashley. I'm a primary care research facilitator for North London RDN. Just, are you collecting ethnicity data? Because obviously obesity is more prevalent in some communities, and it'd be very interesting to see or to hear from you what you've actually found so far in terms of ethnicity.
Chris, do you want to?
Yeah, we collect ethnicity data. We haven't seen a difference in effect size for at least our intervention through ethnicity, and we get people from every ethnicity come through the program because it's nationally available. The most interesting effect size that we actually see is people 60 and above actually tend to have the best outcomes, which is kind of contrary to what most people would say for a digital intervention. Oh, okay. Once you're over a certain age, you can't use an app, and funnily enough, we see the opposite.
And I'd say, phase 3 registration trials are run globally, so that's usually in hundreds of centres, perhaps several hundred centres. So that's North America, South America, Europe, Asia. So there's a good broad sort of inclusion across ancestries. But that said, I think it's increasingly something we index on at every stage of clinical development, and when we consider, as Bill's alluded to, when we use, say, human genetic data to inform new target selection and triage, that we have that in mind increasingly. So I think it's a great question, something we need to keep in mind.
There's a question over here.
My name is Kevin. My background is community GP. I was working in a rural area in Bali, which has a lot of obesity and metabolic diseases as well. I'm currently studying global health management at Imperial. Actually, it's not a question. If I can give one sentence, I think there's several times that the panelists mentioned about primary care, wraparound care, those kind of things. However, reflecting back to my time when I was working as in public health, especially I think maybe it's a different culture. However, in here, there's a lot of obsessions to push everything back to individual and not kind of work with the community or work with the kind of working with families, which is something that I do think the Indonesian healthcare systems was quite robust in that sense, because I feel that a lot of things could be addressed through a family and community approach, because I kind of think that a lot of things that when you push everything to an individual level, it kind of stop at like we become pessimistic, and the discussions becomes like, can we fund this or not? But then how can we actually empower, make a kind of a policy approach that can empower the community and change the culture? Because when I work in a rural village, obesity is much more than an individual problem. It's a culture that they use. Like I would give one example. In Bali, they basically create offerings because they're a majority Hindu, and whilst they create these offerings, because also the refined sugar and a lot of those cakes, when they're preparing them, they're eating them, and these are the particular interesting habits that they have because of in the 21st century, but at the same time, it's so intertwined with culture, and you cannot say that you cannot do the offering and then eat it, because that's part of the culture. I think those kind of things needs to be taken into account in order for us to have a bit more successful obesity management. Thank you.
So does anyone want to come back with that about management and community?
Well, Western culture, right? We're in the century of the self. We're incredibly individualistic. I totally agree. If you can involve the family, I don't know how we change the culture of a whole nation. I mean, you only need to look at Japan and their rates of obesity, which is extraordinarily low, which is curious for a diet which is actually very high in carbohydrate, to try and understand more clearly there are some cultural things going on to lead to this. If you can involve family more, I totally agree.
I mean, I would say from our Imperial BRC, we do actually do our best, but we're targeting only small groups. But all the different culture groups, ethnicities, and do go out to the different communities. But it's a challenge. We're only sort of targeting a very small number, but there are efforts in doing this, and again, challenge. I agree with you. Targeting obesity, it's not just about making one specific change. It's actually everything that's around you.
So we're in the last 5 minutes, so we're going to increase the speed at which we move at, because there's one question I want to come back at the very end. So very quickly, yeah. Do we have the microphones on this side? Yeah. So one sentence.
From Constructive Bio, also ex-AstraZeneca. So my question is actually going back to the therapeutics. So what would the next generation of differentiated asset look like? Is it that we want better efficacy, better bioavailability, or is it, we need more of these dual or triple agonists? Or is it a longer acting molecule for more better patient compliance?
Quick fire answers?
All of the above, but basically optionality, so orals as well as injectables, less frequent injections, and additional mechanisms overlapping the current ones, extending them such that there will be options, and then patients and physicians can find what works for individual patients, hopefully.
And one other element is the ability to rapidly get on an efficacious dose without side effects. And make it easier to do that, because at the moment, as you know, most of these drugs need quite careful titration and cause GI side effects, so that may be another aspect.
Tricia, any comment to make? No? If not, we'll move on then. I think, have you already got a microphone? No? Well, okay.
Hi, my question kind of goes back to the ethnicity question in terms of percentage of male versus female that are currently obese in the country. And when we're looking at prevention of obesity, are we taking into consideration that women might develop or might have PCOS that actually makes them more predisposed to becoming obese? So I just want to know about that data.
I think from the clinical trials, we tend to get more women than men, and I think that is an issue because actually men tend to have more cardiovascular risk. Women have other things like PCOS, so I think we have to be careful that we cover both sexes.
But I would say that young women of reproductive age are neglected. That's been something that I've been trying to have addressed, but people are scared, right? Because the preclinical data, suggests that it's not safe in pregnancy, and therefore there's a big gap. And actually, if you see people who are buying these drugs are young women of reproductive age.
Chris?
So in our consumer market, it is 95%, if not higher, female. What is more curious, though, is within our NHS business, it's pretty much 50-50, which is really interesting. The funny thing is men don't tend to want to go out and pay for a weight loss program, right? If you look at, it's just not a real market for men to do that. But weirdly, when a doctor tells you to do it, men seem to go and take action, which is why in our NHS business, it's more 50-50. It's just one of those odd impacts.
One last very quick question.
I'll try to be very quick. So I'm Huma. I'm a commercial project manager working with Imperial College Projects Limited. I'm also a nutritional advisor and a level 4 personal trainer specialising in weight management for obese and diabetic clients. So my question is mainly for you, Chris, with your business Second Nature. And I was very pleased to hear that your business focuses on mindset and behaviour. Just wanting to know whether you pair that with nutritional advice and a rigid exercise program to provide a holistic approach to weight management. And does your formula take into account hormone issues such as low thyroid function?
Just set me up so I can pitch. This is great.
Well, you're going to have to pitch in less than 1 minute.
The 10-second answer is we pair everyone on our program with an RD registered dietitian, and for some people we also give them a multidisciplinary team. So nutrition is a huge part of our program. I didn't quite catch the thyroid question, but
So providing an exercise routine and nutritional advice for somebody that has hormone issues, it's not going to work for them because when hormones are involved, weight loss is a completely different ballgame.
Yeah. Hopefully it's covered by the registered dietitians on the program who are trained in that, right?
Okay, I'm going to come back now, just very quickly, one sentence, right across the panel. What does the future look like? What is it that's going to make the dish? What's going to be the next tipping point?
If you look forward 10 to 15 years, if you can imagine that there are oral medications with very low side effects that are personalised to the individual, then I think you can eradicate obesity, and that's quite exciting.
Okay. Matthew?
Well, I'd agree with that, of course. And nearer term, I think also just more optionality, so more medicines that all have meaningful efficacy and provide, greater options for patients and physicians.
Okay.
I'm going to change your question a bit by just saying I think what we need to be doing is actually changing how we invest in the NHS so that patients can access these treatments, so that we can actually incorporate it into their management. That would be, I think, a really key thing, because these drugs are available, but patients within the NHS cannot access them.
Bill?
I was going to say oral, but you said it, so what I'll say next one would be there'll be drugs that can give 30% weight loss, as opposed to the best now is about 20%. And if we can get 30% weight loss, we can really change the game for people with very high BMIs and lots of complications.
Can I say something particularly annoying about that, though?
Yeah.
I would love it if... So publishing kind of 1-year weight loss outcomes is a big landmark thing. I think that may be a mistake, because you just get a really high rate of weight loss. People lose a whole bunch of body weight. I know you're probably more talking about sustained 30% loss, but I think because it plays so well for share price, I think sometimes headline figures on weight loss get published, and then you get all the reports of people losing a whole bunch of lean muscle mass. So I think having a North Star of this is a whole other debate, right? But,
we were just teeing us up, but I think just to add a little bit underview, I think also that the food systems and the exercise systems that we have in the country have also got to come in line with that. We've got to accept that we've got to actually change the way that we live our lives right from the very start. I just want you to join with us. It's been absolutely fantastic panel. I hope you've really enjoyed this session.